A very warm good afternoon, everyone, and thanks for the chairpersons. I am speaking on behalf of Dr. Mahadevan, cardiodiabetologist. His talk will be choosing the drug in elderly, which are the anti-diabetics, which will be better in the case of elderly population. So, we know that the population of elderly patients with diabetes is rapidly growing, and it will be double in the next 20 years as the population ages. And more than 25% of the adults of more than 65 years of age are having diabetes, and older adults with diabetes have the highest rate of complications. And not only that, the older adults with diabetes also has higher risk of both acute and chronic complications of diabetes, including major lower extremity amputations, myocardial infarctions, visual impairments, and end-stage renal disease. And patients who are more than 75 years are more likely to develop complications also. So, and not all older adults are not the same, because diabetes management in older adults presents due to a variability in the extensive variability within this population in terms of clinical presentation, psychosocial environment, and resource availability. A person's living situation and the degree of available social support also influences the diabetes management, and it differs across the spectrum according to where the elderly patients live, whether they are living in the community dwelling or live in an assisted living facility or in a nursing home. So all these factors make the older adults to have the diabetes management different. So these are all the few characteristics of older adults in different living situations. So coming to the community dwelling, so these patient characteristics may be different. There may be high functioning adults, older adults, medically stable, and some may or may not need caregivers. All these populations of elderly population will have different impact on diabetes care. Similarly, those living in an assisted living facility also are classified according to the characteristics, and the impact of diabetes care are different. So, elderly people with diabetes with high functioning and metabolically stable can perform self-care and may or may not need caregivers. For those who are unable to follow instructions, manage their own medication regimes, diabetes management may be tricky and dangerous. So the aging population with diabetes have a higher risk of other conditions, the so-called geriatric syndromes that include cognitive dysfunction, depression, physical disability, pain, polypharmacy, urinary incontinence. All these giants, geriatric giants, also will be coming to play in the management of diabetes in the elderly. So the goal of diabetes management also differs depending upon the presence or absence of these comorbidities, as well as the patient's living situations and the available resources. So the other challenges is a high frequency of acute illness and frequent changes in the overall health, which can affect the glucose control and lead to decline in cognitive functioning and physical status. So the treatment goals for diabetes in elderly can be classified into three types. So for those who are healthy, the HbA1c goal is less than 7.5. The healthy means those who have few comorbidities and functionally and cognitively intact. And the second class is the elderly with complex or intermediate in characteristic features, such as they may be having multiple comorbidities, 2 or more impairments, or mild to moderate cognitive impairment. In those group, we need to achieve a HbA1c goal of less than 8. We need to have a lenient. And very complex or poor health elderly individuals are the HbA1c goal is very lenient, and it's less than 8.5. So those are who are residing in the long-term care facility, end-stage renal disease, 2 or more impairments, and severe cognitive impairment. So by this way, we are classifying the goals for HbA1c into three classes. And we know that the risk of hypoglycemia is also very worst in the case of elderly, and the incidence is also more because of the lot of comorbidities and lot of polypharmacies, poor oral intake, and the recognition is also will be difficult in the case of elderly, because hypoglycemia may mimic in elderly patients in a very different way. The patient may behave will not have very typical autonomic symptoms. They may have autonomic, hypoglycemia, unawareness may be there. They may be having just confusion alone, or they may be misbehaving as a stroke. So a lot of recognition can also be difficult in case of elderly. So always, whenever an elderly patient coming in altered sensorium, always do a blood sugar. And similarly, the outcomes with the hypoglycemia in an elderly patient will be also worse, because they may precipitate cardiovascular event and may worsen the cognitive function and lead to poor outcomes. And there may be also an increase in falls and fractures, fear of falling, and confusion may be there, delirium, and symptoms such as fatigue, dizziness, everything may occur. So hypoglycemia is going to be the most problematic in elderly, so this needs to be considered. And A1C estimation in elderly, that also has some amount of problems. So elderly per se can have an falsely elevated HbA1c due to an elevated insulin resistance, and several other comorbidities such as anemia usually coexist with elderly. In the elderly may also have an falsely elevated A1c. So these things to be considered. And other, already we have discussed the common geriatric syndromes associated with the diabetes, such as cognitive dysfunction, depression, physical disabilities, polypharmacy, and medical non-compliance. All these should be considered, and the strategies for optimizing these should be there. So it should be a holistic care should be given for the elderly people, not only addressing the diabetes management. And these are all the few factors which may elevate or falsely decrease HbA1c. So coming to the management, lifestyle modification is the important as a starting for all patients with diabetes, including older adults. So very restricted diets are not advocated for older adults. So counseling to avoid large carbohydrate loads at any one meal, that will be more suffice for them. So they have to avoid large carbohydrate load at any one meal. That will reduce the glucose excursions without unnecessary dietary restrictions. And exercise is also very much important for them, because they are more prone for sarcopenia and frailty. So it should be, patients should be encouraged to have physical abilities when developing an exercise plan. And the ideal plan will be encouraged. Those who are older adults who are not very active should also be encouraged to walk at least 5 to 10 minutes, 2 to 3 times a day inside the house. And the elderly diabetics should be guided to the activities according to their functional capabilities. And prior to the physical activity, high risk symptomatic individuals should be screened for CAD. And the recommendation is moderate aerobic activity of at least 5 days for 30 minutes, similar to that of other diabetic population is advocated. And muscle strengthening exercise should also be advocated for, because of the propensity cause sarcopenia, the incidence of sarcopenia. The muscle strengthening exercise at least 15 minutes per day, at least 3 times a week should be done. And regarding the balance control, they should be advocated with, they should be advised with the physiotherapist to have a proper balance control. So all these things should be addressed. And coming to the medical nutrition therapy, once again, so because they do have a deterioration in the taste, additional illnesses, all these things should be considered, and proper advice should be given. So coming to the management, pharmacotherapy, so with the available OAD and parenteral anti-diabetic drugs, few drugs has advantages and few drugs has disadvantages. So coming to one by one, so biguanides, so relatively they are safe with if there is no contraindication, low risk of hypoglycemia, low cost. But the problem will be the patient will usually have GI intolerance. So and also may cause weight loss in frail older individuals. So already the patient might be having lower intake, maybe further they will be worsened on taking metformin, and they may also have an associated vitamin B12 deficiency as a side effect of metformin. So these things should be considered. Coming to sulfonylurea, the main advantage is low cost, but the problem will be hypoglycemia risk. So better glibenclamide should be avoided, and it should not be given to any elderly patients. If at all, if you want to select a sulfonylurea, it's better you go by short-acting sulfonylurea, that is glipizide. And in a minimal dose, that will be more better. Coming to meglitinides, they are also non-sulfonylurea insulin secretagogues. So they do have some, because of the shorter duration action, the hypoglycemia risk is relatively less compared to sulfonylurea. And we can skip the dose if the meal is skipped. That's the advantage. No meal, no dose. So by that we can use this meglitinide, that is especially ripaglinide. Coming to the GLP-1 receptor agonist, they are mainly considered in overweight individuals, and the risk of hypoglycemia is less. but they are available in parental form, that's a problem. And nausea, vomiting, diarrhea also is there, and the higher, cost is being higher also, and limited safety profile in older adults. So coming to the DPP-4 inhibitor, so they are relatively safe compared to sulfonylurea and all other drugs. DPP-4 are relatively safe. They do have a low risk of hypoglycemia, except for very few minor side effects such as nausea, vomiting, nasopharyngitis. They are very relatively safe, and cost is also nowadays it's come down, and well tolerated by elderly. So thiazolidine indiones, the risk of hypoglycemia less, but they are more prone for fluid accumulation. So those who are at risk of developing congestive heart failure should be taken care, and it should be avoided. And there is an increased risk of bone loss, and fracture risk is high with usage of pioglitazone. And there is also a concern about bladder cancer. So it's better to be avoided, or it should be used very minimal dose. In a very minimal dose it can use. SGLT2 inhibitors, the risk of hypoglycemia is less, but the benefits for patients with atherosclerotic, CAD, as well as congestive heart failure is very high, and also renal failure patients, it's very much useful. And the main problem or concern with SGLT2 is the increased risk of urogenital infections, either mycosis as well as bacterial infections. And dehydration is one of the more important problem with profound glycosuria, which is induced by, and the patient may have even euglycemic ketosis. So the patient may have just or vague symptoms. The patient may feel very excessive tiredness like that. The ketone may be positive. So on taking this SGLT2 inhibitors, and they are more common in elderly individuals. We do come across such type of patients, and weight loss, everything is there. So we can use, but in a very safety concern. Insulin seems to be somewhat better. The problem is only parenteral, and the best regime will be basal insulin along with minimal oral OAD drugs. That will be more better for any elderly individuals. And we have to always watch for hypoglycemia in any individuals who are on insulin. And the meal predictability may also problem whenever we are using human insulins. So at times the elderly patients may skip the meal. So in that case, it's better you go for analogs. So suppose the patient is not taking the meal, you can skip, or if you want, if the patient is taking the meal, even after the food, you can take insulin. So by that way, insulin analogs scores over better, and basal insulin is more better. And in nutshell, so these are all the recommendations. Glibenclamide should not be used for under any circumstances. And coming to individual group, already I have discussed. So glipizide may be preferred, and also gliclazide may also one of the low dose gliclazide can also be one of the sulfonylurea which can be used. And coming to meglitinides, that is ripaglinide can be used. Alpha glucose inhibitors, once again they do good with for postprandial control, but the problem will be it will reduce the appetite. So the patient may have some indigestion, diarrhea. So in that case, AGI are not good in elderly population. And the word about DPP-4 inhibitor is, apart from they are very safe and neutral in elderly, they also improve cognition. And there are studies has been quoted, and this GLP-1, which is being elevated by DPP-4 inhibitor usage, is acting on the brain, and it will be neuroprotective, and it causes improved cognition, and which is evidenced by this MMSE score. So maybe in that way also DPP-4 seems to be somewhat better. And we have to always consider renal and renal impairment if the patient is there, patient is having. We have to choose the drugs accordingly. Already we have discussed the SGLT2 inhibitors. Osmotic diuresis may cause dehydration, and there is an increase in the frequency of genital and urinary symptoms, urinary infections, and weight loss is also there. And these are all the concerns. And frailty and fracture is also one of the main thing, side effect which can occur with the SGLT2 inhibitors. So we have to use very cautiously. And insulin therapy, already I have told this basal insulin with OAD, once daily basal, and that in the morning. Basal insulin in the morning time, one time basal insulin with OAD is a more easy way of managing elderly. If at all, you can go with the idea is we should not go for very complicated insulin regime. Is better to be avoided. So these are all the things. There's nothing. To conclude, so diabetes is one of the most common lifelong chronic diseases in the world, and its ratio is increasing by aging population. So elderly patients with type 2 DM have an increased risk for CAD, stroke, and vascular diseases. So the treatment target and treatment absence in elderly individuals depends upon the functional capacity of the individual, comorbid diseases, treatment compliance, all should be evaluated, and accordingly we have to give a better regime. And when starting OAD or insulin therapy in the elderly, treatment regime should be simple and must have few drugs as possible. And drug therapy should not be initiated unless it is necessary, and if necessary must start with low dose, and low dose increase should be done slowly. All patients should be evaluated with liver and kidney tests before onset of treatment. Thank you. Thank you for patience listening.